I'm Dr. Ahmed Lotfi. I'm a senior consultant obstetrician and gynecologist. I've been practicing in UK, New Zealand, and in the Middle East. My qualifications are MBCHB, master's degree, and MRCOG. This presentation is about abnormal labor. Abnormal labor dystocia refers to deviation from the normal pattern of labor, with delays in cervical dilatation or fetal descent. It increases the maternal and neonatal risks, especially dangerous where surgical services are limited. Common types of abnormal labor. Abnormal presentations, breech, shoulder, face, or brow will lead to abnormal labor. Prolonged labor, more than 12 hours prima gravida, or 8 hours in multipara. Obstructed labor, no descent despite strong contractions. Precipitate labor, if the labors happen in less than 3 hours total. Prolonged second stage, more than 2 hours prima gravida. Active second stage, more than 2 hours prima gravida, or 1 hour multipara. Prolonged labor, definition, labor exceeds normal duration. In prima gravida, more than 12 hours. In multipara, more than 8 hours. Causes, inefficient contractions, cephalopelvic disproportion, and malposition or presentation. Risks, exhaustion, dehydration, infection, uterine rupture. Obstructed labors, this labors is not progressing despite strong contractions. Causes, cephalopelvic disproportion, malpresentation, pelvic abnormalities. The signs, no descent, bundles ring in the abdominal examination, and bladder is distended. These patients need immediate cesarean section. Precipitate labor, definition, labor lasting less than 3 hours in total. Risks, perineal trauma, postpartum hemorrhage, and fetal distress. Prolonged second stage, prolonged active second stage after 2 hours of pushing in prima gravida, or 1 hour in multipara. This is prolonged second stage. Usually we give 1 hour passive second stage in prima gravida and 30 minutes in multipara. Causes, poor pushing, malposition, or it is the effects of analgesia. The management, encourage pushing, empty the bladder, consider instrumental delivery, vacuum, or forceps. Diagnosis, this condition can be only diagnosed by the use of the partograph to track labor. Vaginal examinations to check dilatations and presentation and position every 4 hours while the patient is in labor. Monitor of contraction and fetal heart rate and maternal vitals, either manually or by CTG. Warning signs, act immediately. Labor with no progress, you should act immediately. Meconium stained fluid with no descent. Maternal fever or foul smelling discharge. Uterine tenderness or rupture or suspected rupture. Absent fetal heart rate. Management, these 3 P's, power, contractions, augment with oxytocin if no obstruction, and the oxytocin for augmentation of contractions, and should be reduced and discontinued if the if there is progress of labor, and should be stopped if there is no progress of labor, and this trial of labor should be ended by delivery. The second P is the passenger. Assess size, position, and presentation. And obviously the fetal condition should be assessed continuously. The passenger, the pelvis, suspect CBD, cephalopelvic disproportion if the pelvis is with inadequate diameters. Key points for frontline workers: use Bartograph for early detection, avoid delay as prolonged labor kills, and Syncytinone should be given for short trial of labor. If there is progress, should be reduced or stopped. And the patient should be counseled that the Syncytinone could increase the risk of fetal distress, uterine hyperstimulation, or uterine rupture. Never use oxytocin when contraindicated, and stop it after establishment of good contractions and progress. Keep mother hydrated and monitor closely. Document and communicate with referral centers. Thank you. This is the end of this presentation.